Okay, this next slide is out of your book. It basically says the same thing, maybe a little more simpler. You've got your etiologic factors here, allowing for activation of pancreatic enzyme or injury to pancreatic cells. Keep in mind this activation of pancreatic enzyme is occurring in the pancreas, and that's not supposed to happen. So then you end up with autodigestion effects of the various pancreatic enzymes. Trypsin allowing for edema, necrosis, and hemorrhage to occur, elastase adding to hemorrhage, the phospholipase A producing fat necrosis, more fat necrosis, and then the kallikrein, edema, vascular permeability, smooth muscle contraction, and shock. Except to know that these are pancreatic enzymes, it's probably not important that you realize this direct effect, like which of these enzymes causes fat necrosis. That would not be something you should spend your time studying, okay? Just know in general that autodigestive effects of these pancreatic enzymes causes this pathological process to occur, damaging the pancreas. All right, if we continue with etiology and patho, just how is it that alcohol produces pancreatitis? Well, maybe it stimulates secretion and excess production of hydrochloric acid. Maybe the decrease in gastric pH causes the secretin hormone to be released. We do know that secretin stimulates pancreatic secretions. It could be that the alcohol causes a regurgitation of duodenal contents in the pancreatic duct, resulting in inflammation. A predominant symptom is going to be abdominal pain. It's in the left upper quadrant. It can be in the mid-epigastrum. It commonly radiates to the back, but that's going to be a predominant symptom. It's a sudden onset of a severe upper abdominal pain. It's unrelenting. It radiates through the back. Remember, your pancreas is a retroperitoneal organ, so any edema, inflammation, or enlargement will cause the backside, the posterior part of your peritoneum, to stretch over the mass of an inflamed pancreas. The abdomen is very tender to touch. Sitting up, leaning forward will help lessen the pain. Flexing the leg can help, especially the left, because it decreases the tension on your abdomen. The pain can follow a large meal and or alcohol. And then vomiting doesn't help. So, when you talked about the duodenal ulcers, the abdominal pain seemed to make a difference. Here it doesn't. Patient can have nausea and vomiting. They'll break out into a cold sweat. They'll be pale. They'll have weakness and anxiety if they're severe. Generally, you're going to see profound dehydration with the associated symptoms. Now, you may see a low-grade fever. These pictures here, you've got Gray-Turner's syndrome on the top. That is a bluish discoloration of the flanks. That happens because these pancreatic enzymes also leak into your skin tissues and allow for destruction of blood vessels and tissue membranes to occur. And then Cullen's sign is a bluish discoloration around your umbilicus, so it's periumbilical. And again, this is the results of seepage from these blood-stained exudates from the pancreas. You're going to see these two symptoms in a severe case. You might have jaundice if there is a biliary obstruction associated with the pancreatitis. The pancreatitis itself would not cause jaundice, but biliary obstruction may occur as a causative thing causing the pancreatitis. Your serum amylase will be elevated, usually 2.5 times the norm, usually within 6 to 12 hours of onset, and it's going to stay up for several days. Amylase facilitates carbohydrate digestion. That's what amylase is supposed to do, and we're supposed to have some of it in our bloodstream, but not this much. Lipase will be up for several days to 2 weeks. And actually, lipase is more specific than amylase. But you can think of amylase and lipase together as being your pancreatic enzymes. And when those are elevated, that's extremely indicative of pancreatitis. It really doesn't say much of anything else. Lipase, up usually 3 to 5 times norm. The normal is 0 to 160 units per liter. Your normal serum amylase is 0 to 125. Urinary amylase, oh, by the way, lipase digests fat. So amylase facilitates carbohydrate digestion, lipase facilitates fat digestion. The rate of amylase secretion into your urine is increased more often. It tends to be elevated higher above the normal range, and it stays elevated longer than your serum amylase level. Things like mumps, cerebral trauma, ectopic pregnancy, bowel, gastric perforations, cholecystitis, and transplantation can also increase your serum amylase levels, but most of the time, when you see an elevated serum amylase, it is pancreatitis, especially when you see amylase and lipase together elevated. Other things that you're going to see. You have glucagons that are released. Rather than decreasing insulin secretion, so you'll see hyperglycemia. You might have both occurring if the islet cells are damaged. So, you know, the patient with acute pancreatitis tends to be hyperglycemic, and it's related more to glucagons being released than to insulins being damaged. Or, actually, I'm not saying that right. The islets of Langerhans can be damaged by pancreatitis, but that's usually not the reason that the patient's hyperglycemic. Lipids go up because you have free fatty acids that are released by the lipase. The lipase breaks down fats, and so then the fatty acids are released. Hypocalcemia occurs and is a very common association and a very common problem electrolyte. Excuse me. Sorry, I need to do that again. There is a word, it's called saponification, which is the digested fats act as a sponge and sponges up the calcium. So you get saponification of calcium by the fatty acids, and these form complexes that have been released from the retroperitoneal fat by lipase digestion. You can also have sequestering of the calcium by the fat in the peritoneum. So this happens when you have severe disease. Hypomagnesemia can also be sequestered in the peritoneal cavity. Another thing about low magnesium is pretty common in alcohol abuse anyway, and it's common because there's something about the way alcohol affects the kidneys, and the kidneys become more, what's the word? Well, they don't hold on to, they allow more magnesium to pass in the urine. So the alcoholic kidney allows more magnesium to pass in the urine. And, of course, we know they don't eat well. So there's several reasons why the patient with pancreatitis has low magnesium. I've mentioned a few. Hyperkalemia, secondary to tissue necrosis. As these tissues are being broken down, the potassium within those cells gets released. The patient experiences metabolic acidosis that also promotes hyperkalemia. All right, got to stop this segment. I'll be back.